Can we go back to the first slide, please? So I'm going to dwell mostly on internal rotation because external rotation I'll share a little bit with you, but external rotation for me is more dynamic than internal rotation. Internal rotation requires certain things. And I'll share with you the opinion not just of myself, but some of my colleagues. So let's take a closer look. And if anybody's wondering who is this guy here, that's Alfred Hitchcock. If you've never heard of him, he's the greatest director to never win an Academy Award. So again, same conflicts of interest. Now, I usually learn from my colleagues, and more than anyone else, I would say Gilles Walsh. This was him in a Zoom call, and I wanted to point out the game that he plays. Over his head, you see there, it says Mastermind Challenge, which is what he was. In any case, he suggested you should consider internal rotation this way. Why is it important? How normal can we make the shoulder? What factors affect biomechanics and outcome? What is the role of VR planning? Maybe none, maybe. What is the role for soft tissue factors, and how well do the experts do? So I asked many of my expert colleagues, many of whom are members of the Codman Shoulder Society, to tell me what they think. And by country, and I understand I've underrepresented some of them, but by country you'd be interested to see that there's a wide range in France, including one who said, I don't know. There is one Swiss surgeon who does better than 50%. There's one Canadian surgeon who said it was 60%. And then in the United States, you can see a lot of question marks, and then ranging all the way down to 30%, 20%, and higher from there. And comments were, it's unpredictable, it's a black box, 135-degree neck shaft angle is critical, and 20 degrees of humeral retroversion, and an eccentric glenoid. Body habitus is important. Obesity is a negative factor. Thoracic contour is important, as Moroder has showed us. And then the subscapularis is important. How many of these guys actually use VR planning? That might be of value for them. And if you look here, you can see the yeses are in green and the no's in black. And it was, for all these particular surgeons, 65%. So we all do different things. Now, Jonathan Levy looked at functional internal rotation after anatomical replacement and after reverse, his own series. And this is how he graded it, as you see here, in terms of how many points he would give. And so for total shoulder arthroplasty, it was 88%. I assume they had intact subscapularises at the time of surgery. They achieved internal rotation above the L1 level. And reverse was 63% for him. So that's at least one good study. Gerber has written about this, and this was just recently, and feels that extension is a critical component of motion to regain internal rotation. And if you have extension below 40 degrees, there's no way you can bring your hand behind your back, even though you may have good rotation and abduction. And I will show you a case like this. And in his experience, 62% with good functional IR, and subjective shoulder value 92%, 38% with a poorer function, and their satisfaction, according to the subjective shoulder value, was lower. George Athwal and Gilles Walsh looked at the mechanics and came to the conclusion that 135-degree neck shaft angle is better than 145, larger glenosphere is better, eccentric sphere is better, 10 millimeters of lateralization is better, and 10 degrees of increased humeral anteversion. This is what they concluded from their study using the software program I mentioned before. And again, BMI had a higher risk of complication and lower functional return of internal rotation. And then bio-RSA, inferior centricity, and subscapularis repair were better. And you've probably seen many examples like this. And just another example as well. And interestingly, I show you two cases on the right side, one with an in-metaphysis lateralized sphere and one with an inferiorized humeral component without lateralization of the sphere. And we'll show a case of this momentarily. This group here found that healing of the subscapularis in reverse shoulder was about 53%, and this directly correlated with functional internal rotation. Now remember I said about fragility of the study. I would suggest that their numbers here are too small to truly conclude that that is indeed correct. And then of course, Philip Moroder explained to us the importance of posture and scapulothoracic orientation, which we're only just beginning to understand, and which none of these models that we've shown, the patient-specific, the virtual reality models, take into account. And this will be, I think, another area that may be incorporated. So I said, well, why don't I look at my patients? Because we have a registry, and unfortunately I don't have the recent data, but when I was doing this certain type of prosthesis here, how happy are my patients? And if the question is, I'm happy I did it, I do it again, it's 98%. If we look at subjective shoulder value greater than 80%, that was 68%, and lower, but still happy, was 30%. Now, I did not specifically correlate to internal rotation. I could go back and do that, but I hadn't done that. So let's look at a few examples. This is a 74-year-old man with a massive rotator cuff tear and a stiff shoulder, passively stiff shoulder as well. And you can see here his motion. And you can see the planning here for, I'm sorry, you can see the anatomy here. And then you can see the planning here for theoretically what we should get with the geometry that we plan for with inferiorization and lateralization as well. And if we look at his motion here, you'll see that he has fair flexion. He's stiff. He bends his elbow to give the impression he has more than 90 degrees of flexion. Functionally, he can put his hand on top of his head. He's quite happy with that. That's not a problem. And you can notice the geometry of the component above, as you see. And look here. He cannot internally rotate, but he has very limited extension. And if I straighten his elbow and show you, this is less than 40 degrees. So I think someone who starts out stiff, it's very difficult to regain their ability for internal rotation because extension is critical to this. And as you'll see here in a moment, if you wondered, his subscapularis is intact based on his belly press sign and his bear hug sign. Internal or liftoff sign is very difficult in people with limited internal rotation. How about another case? This is a 63-year-old female with bilateral rotator cuff tear arthropathy. In VR planning on the right side, you can see here what she has in terms of her deformity. And you can see my plan here for a bio-RSA. And, you know, the planning for extension is not so great. And I just couldn't make it any better than that. I used this particular stem. And the other one, I planned for more lateralization with a different component and perhaps had better internal rotation. This one's 109 degrees of internal rotation, and extension is 36 degrees. So how did she do? You can see her x-rays for each shoulder, and I put the two surgeons on the left who favor inferiorization and on the right who favor lateralizing. And so she has excellent flexion. And she has, as you'll see in a moment, excellent external rotation, easily able to put her hand on top of her head. And with the arms at the side, pretty good external rotation as well. But it was a bit of a surprise for me when she turns around. Look at her internal rotation. And remember, both have a reverse. So this is one side. And then she sort of grasps the other arm, and I say, take this away. And she'll show you she's almost the same on the other side. So it's a bit confusing, isn't it? And here is another, well, before I go further, the one thing this patient told me is on the side that was inferiorized, she didn't like the way it looked. And you can see that you lose the deltoid wrap. And on the other side, she was much happier because of the appearance of her shoulder with lateralization and better deltoid wrap. Now, this is an interesting case because there was no planning. This was a failure of the glenoid. Actually, it was a base plate failure when the man fell. And I retained the humeral component and converted this to a hybrid, if you will, using a different component that was lateralized. And with no planning, you can see an interesting function for him because he has no subscapularis at all. And at the time of revision, there was nothing there at all. And so you see he can raise his arm relatively okay in a revision setting. He has no pain at all. And as you'll see here in a moment, his internal rotation is going to be quite surprising. Remember, no subscapularis and no planning. So he was quite happy with that, and I think I show you here his exam that shows he's very weak in terms of his belly press sign and his bear hug sign, and so his subscapularis clearly is not there anymore. You can see here. Quite weak, and the same for the bear hug sign. Okay. So just a brief word on external rotation, because I think this is something we should all be aware of. Is there a role for tendon transfer? And I will show you a patient with two different operations, one on the left with no transfer and one on the right with a transfer. And her pain is about the same. She's without much symptoms. Let's see, is that working and running? Yeah, so what's the difference between these two? As we'll see in a moment. So I say to her, raise your arms up. It looks pretty similar. And she's okay with this and telling me that she's quite fine, thank you very much, except she doesn't like the left as much as the right. When I say put your hand on top of your shoulder, you see she extends her elbow on the left, and she has to use her right hand to bring the left one on top of her shoulder, on top of her head or behind her head. And if you test the external rotation lag, there is none on the side that had the tendon transfer. As opposed to, and you can see she can activate latissimus dorsi by adducting and externally rotating at the same time. And you can do this at the side, or you can do this in abduction, but it's a useful way to train the patient, and you can use cutaneous biofeedback in people that are having trouble to activate the latissimus for external rotation, because of course it doesn't do that. Again, you see here, she has minimal lag sign, and if I ask her to pull downward on my hand, she doesn't have any lag at all, because she activates the latissimus. Now, if we look at the other side, the one that did not have the tendon transfer, you can see here that she will have a lag sign. That's relatively significant. And then if I put her in abduction, she will also have a lag sign. And so the logical question you might ask me is, how frequently do I do this? In our published study, it was 14% of all my cases. So we know from these studies the importance of the teres minor, and you can look at these two patients and know that one may have a lag sign because the teres minor is all fatty atrophy. And if you know that, you can avoid this situation like in this patient, where she has a significant lag sign, and you look at her face, what you can see, and she's not so happy. And it's important you identify this before you go to the operating room. So I do a version of what Pascal Bourlot has described, although we don't use the teres anymore. We just use the latissimus, because when using the teres, we had some compression of the axillary nerve, and we avoid that now. So, σας ευχαριστώ πάρα πολύ.